12:30. Welcome to this lunchtime symposium on topical oxygen. My name is Keith Harding and I have the privilege of moderating this session and I'm confident that you'll learn an awful lot from the three speakers that we've lined up for you. What we'll do is take the speakers one at a time and have questions and answers after each presentation, and then if we have time, bearing in mind other sessions follow on from this, we'll have a general discussion at the end. Why oxygen? Isn't it the food of life? Isn't it the source of all good things? So therefore, it does make sense that we're talking about oxygen. First up is an interesting, if not amazing, man from the United States, Dr. Thomas Serena, who's given more lectures than I've had hot dinners, and God knows I've had a lot of hot dinners. He's the founder and medical director of the Serena Group, a global healthcare company focused on wound care. He's been the lead or principal investigator in over 100 trials that have included a range of simple dressings all the way through to gene therapy. He has been instrumental in setting up a lot of activities around the wound space, not only in the United States, but also globally. Also is a hyperbaric oxygen physician as well, so he should know a bit about oxygen. Dr. Serena, sir.
Thank you, sir. So, in the United States, it would be very unusual to see a hyperbaric physician talking about topical oxygen. Most of the hyperbaric physicians there feel somewhat threatened. So I think it was only natural for us to do the clinical trials on topical oxygen. And in the second half of my lecture, what I'll do is describe the clinical trial that we conducted in 19 centers throughout the United States. But first, Jane Clark had asked me to talk a little bit about oxygen itself and how it might work. And this is the device that we're speaking about today. This is the Natrox system. It's very simple. You can see it's small. It's got the little wagon wheel that delivers the oxygen that diffuses into the wound. I'm not going to go into great detail about how it works, but you basically have an oxygen generator that pulls oxygen out of the air, and then it diffuses into the wound. And there's a number of different ways to deliver oxygen to the wound. There's hyperbaric oxygen. You can put the patient in a bag, such as the AOD device that is in there. But most of the research on diabetic foot ulcers and other wounds has been done with diffusing oxygen into the wound, in which the oxygen makes direct contact with the wound bed. We know that oxygen is important in wound healing. In every phase of wound healing, it increases how the neutrophils kill and other leukocytes. It inhibits the growth of anaerobic bacteria, causes collagen to form more effectively, supports cells, drives angiogenesis, and we're not going to talk about, there's one study that demonstrates topical oxygen also increases vascular endothelial growth factor. In addition, keratinocytes love oxygen, and we'll talk a little bit about that later. So I like to think about topical oxygen as three basic effects. Now, this is not comprehensive. There's more than these three, but these are the three that I've picked on, if you will. And so I'm going to describe how I think they work, and I think there's fairly good evidence for it. There is most certainly an antimicrobial effect. Well, of course, if there's oxygen in the wound, anaerobic bacteria, which are found in wounds in levels up to 20% when you do accurate culturing, are not going to be able to grow. They'll be inhibited. But there's more than that. We know that neutrophils and other leukocytes kill through an oxygen burst. They take in the bacteria into this little phagosome, and then they put free oxygen radicals. And free oxygen radicals are highly reactive, and it makes sense if you're using free oxygen radicals to kill bacteria, you got to have a source of that free oxygen radical, and that's oxygen. So I think one of the mainstays of how this device will work is by making neutrophils kill more effectively. There's also an interesting phenomenon with the wound microbiome, something we've been studying a great deal lately. And if you look as the wound goes through acute colonization, transitions into a wound that has too much bacteria, and then becomes polymicrobial, including biofilms, the wound tends to go more become more chronic. But at the same time, the microbiome through each of these phases is changing, and it's not changing in a good way. It's changing in an unfavorable way that is going to inhibit wound healing. And there's an interesting effect that's been studied with topical oxygen, in which when you expose the wound to topical oxygen, you change that microbiome. And this is a fairly small study, and there's more of these going on as we speak. But as you see, the nature of the bacteria changes as we go, as we add topical oxygen. And this may play a very important role in how it works. So the neutrophils and other leukocytes kill better in a high oxygen environment. And in addition, the microbiome changes to one that is more favorable towards healing. The second is related to energy production, and we know that a very important enzyme, cytochrome C oxidase, is on these mitochondria, and that's an oxygen-dependent enzyme. So the more oxygen that you give mitochondria, and other cells for that matter, but the more cellular organelles, but the more you give oxygen, the better that enzyme works. And there's been some studies on cytochrome C oxidase and others which really demonstrate that oxygen can supercharge your mitochondria, which is again going to facilitate wound healing. In rat studies, what they found was that in low oxygen environments, the mitochondria do not produce as much cellular energy or ATP. If you put the patient in normal baric or higher doses of oxygen, such as topical oxygen, the mitochondria are more efficient, they produce more energy. So number one is an antimicrobial effect, and number two is this effect that's related to increased cellular energy. The third is that keratinocytes love oxygen. And ever since T.K. Hunt studied this all the way back in the 70s and 80s, and I remember T.K. telling me that keratinocytes love, it's like throwing fuel on the fire. And so both in animal studies and human studies, we've seen that you get greater epithelialization with oxygenation. And this is just an example from one of our patients with a venous leg ulcer. It looks pretty clean. It's a pretty good-looking ulcer. Looks like it should heal. What it really needs now is epithelialization, and the addition of topical oxygen therapy creates an environment that is very favorable to keratinocyte migration. This is another example with a diabetic foot ulcer. I was testing this theory. Does adding oxygen really accelerate healing? And as you can see, in a rather rapid fashion, we're able to get the ulcer healed by the addition of oxygen. The wound bed was already prepared. The patient had already had control of the bacterial burden, and what we really needed was epithelialization at that point, and that's what we got. All right, so I'm going to shift gears now and talk about the clinical evidence for topical oxygen, and I'm going to focus on diabetic foot ulcers. Now, we use topical oxygen in other settings, of course, but for the first part of this lecture, I'm going to focus on that. So when you look at continuous diffusion of oxygen, there have been several studies that have demonstrated that its efficacy, and now we have a meta-analysis that should be coming out in the next month or so, looking at all of the evidence that's been published in both the U.S. and international literature that demonstrates that topical oxygen is effective in promoting the closure of diabetic ulcers when compared to standard of care. All right. So CMS, the Centers for Medicaid Services. Now, CMS rules my life, because they pay us in the United States, and they had a lot of influence into the design of the clinical trial, which, to me, even when I say it now, it sounds unusual. But why would a payer have such influence into the trial design? Because if you don't design the trial correctly, they won't pay you and they can't use the product. So it's actually pretty simple, and it comes down to just to money. But they had certain requirements that they wanted in their clinical trial. And the big complaint that they had to those of us that do clinical trials was, you're not treating our patients. So what we did is we went out and looked at the criteria that CMS produced for advanced wound therapy. And we took those criteria and we incorporated them into our Natrox clinical trial. So that when Medicare came back to us and said, what about this trial? We said, no, this trial was for your patients. Their patients included those older than 65 years of age. So more than half of the patients in this trial were over 65. They complained about standard of care. You don't really do standard of care. Every patient in this diabetic foot ulcer trial got total contact casting for 12 weeks. Every patient got aggressive debridement. So we followed the guidelines to the T for Centers for Medicaid Services and the trial design. Also, they said that you don't use advanced therapy until the wound has failed standard therapy for 30 days. So we screened the patients for 30 days and screened them very aggressively. Aggressive debridement, total contact casting. If you healed by more than 40% in those 30 days, you were eliminated from the trial, and actually that was the #1 reason that patients were removed from the trial, that didn't enter. They would come with wounds that have been there for weeks and weeks. Some of these came from major universities, and if I told you the name of the folks, that you would recognize them as they stand on the podium. And they sent us patients who hadn't healed in 6 months, and we put them in aggressive debridement, total contact casting, controlled the bacterial burden, and lo and behold, they start healing like gangbusters. And they can't get in the trial because they don't meet that criteria. They've healed by more than 40% in 4 weeks. So I usually complain about CMS and our payer, but this is one instance where I think their advice was fairly sound. And we were able to design this trial, and I will tell you that after this, we are now following this design for all of our diabetic foot ulcer trials, and that's something that will come out in publication this year. All right, so let me just go back over that again. So all the patients had to have a 4-week run-in period, and they got very aggressive standard of care. Again, debridement, reduced bacterial burden, total contact casting. And again, at least half of the patients, by Medicare's requirement, had to be over the age of 65, and I think the final number was somewhere in a range of 52 or 53%. They were then randomized to receive topical oxygen therapy and standard of care, or standard of care alone, and the trial was 12 weeks in length. We had 19 clinical sites stretched across the United States, and you can see there are several of the investigators on the publication line below. So the run-in period was to establish the chronicity of the wounds, and the wounds could not have healed again by more than 40% in 4 weeks, and actually we broke that down into 2 periods. There was 2 weeks that we followed them, and they couldn't heal by 20%, and the next 2 weeks they couldn't follow by 20 weeks. So they were given sharp debridement. We used topical antimicrobials as well as total contact casting, and excluded anybody that healed. And this was the biggest reason for screen fails. And I have to give kudos to Craig and the other folks at Intertech, because there's nothing like being the sponsor of a clinical trial and having patients screen fail out, because it costs you money and you don't get anything for it. But they were very patient with me, and they allowed me to continue with this very high screen failure rate. All right. So we also used digital planimetry to follow all the patients on a weekly basis, and this was all, we both did 3D and 2D measurements. This was all included put in the cloud. The interesting thing about this also is because part of this trial was run during the pandemic, and the interesting thing was that we monitored, because it was all done digitally, we were able to monitor the sites on a weekly basis. So they get intense monitoring. In addition, every single patient had to be reviewed by one of the clinical trial staff before being enrolled. So we really put a lot of quality control. And I can tell you that I eliminated quite a few patients. The trial site would send a picture, and I would say, it doesn't look like you debrided that very well. And I would call the investigator and say, get your scalpel out, because you have got to debride this wound, because it's simply not going to heal if you don't. And we got into a number of arguments about debridement and inclusion, but I won them all because I was writing the checks. So but it allowed for a large amount of control. And this also led to another trial design that I don't have time to go into, but our current diabetic foot ulcer clinical trials, we don't visit the sites at all. We've just completed another 100 patients of enrollment, and I'd never been to a site. Everything is done completely in a decentralized or virtual fashion. All right. So looking at the baseline characteristics of the patients that were enrolled in the trial, pretty much the area was fairly similar. The duration of the wounds was much longer than I would have anticipated for the trial. but you can see that that most of them ulcers had been there for quite some time. The ISDA grade is signs of infection, and again, you weren't allowed in. Couldn't enroll if you had a serious signs of infection. And then Wagner grade, which we have to use in the U.S. for reimbursement, was Wagner 1 and 2, and they were all Wagner 1 and 2s. But you can see the important thing here is that the patients were well distributed between the standard of care arm and the standard of care plus topical oxygen therapy, or Natrox. 54.5% of these patients were 65 years of age or older. Has anybody here ever total contact casted the geriatric population? It's a challenge to put an 80-year-old in a total contact cast. And we had, it was really something that I had never faced before, because oftentimes for our elderly population, we won't put them in a cast because they're unstable. And we had spent quite a bit of time working on methodologies to get these patients into casting. This is our consort diagram, and you can see that we had 224 patients that were eligible for enrollment, and then there's this large dropout number. You can see that we excluded some 29 in the first week and then 50. The main reason, again, they healed too quickly. So my supposition here, and I think I'm right, is that the reason that these patients dropped out is because all they really needed was true standard of care, which is total contact casting, controlled the antimicrobial burden, and good debridement. And when they got that, they were dropped out. But when they reached the point of randomization, we were able to enroll 145. They were then randomized by a randomization schedule. We ended up with 81 in the total topical oxygen and 64 in the standard of care. There's a little bit more in the topical oxygen trial side of it. This has to do with the pandemic, like everything else, and so we were in the second half of it, and we had patients getting COVID during the trial. It was really a nightmare for a few weeks, and so we ended up having more patients in the total topical oxygen because we had some early dropouts in the standard of care arm. What you see is that you look below and you see the outcomes. In the standard of care arm, we had 18 healed. In the topical oxygen Natrox arm, 36 healed. And then we had a number that were withdrawn and not evaluable. Again, the vast majority of these dropouts here were COVID related because again, this happened, the pandemic hit us right in the middle of a clinical trial, and I hope there's no more variants for that to happen again, because it's really quite a challenge. These healing rates are not as high as you've seen in other diabetic foot ulcer clinical trials. It's the trial design that is the reason for this, because we took all the fast healers out. So these patients are the patients that will benefit from advanced therapy. So by removing the fast healers, you do have a lower healing rate, but actually you're treating the patients that really need the therapy. And for us, with that CMS I just mentioned, those patients are the ones that who are going to get reimbursed for treatment. All right, so looking at the complete healing outcomes, you can see 18 healed in the standard of care and 36 in the topical oxygen. Interesting enough as well, when you look at the per protocol, you have the strongly positive finding, and that is patients that completely followed the protocol. There's a really big difference between standard of care and topical oxygen. And most of your diabetic ulcer studies will report per protocol. But we hit intent to treat. Now, statistically, what does that mean? Intent to treat is everybody that gets enrolled is included in the analysis. So if you only had topical oxygen for 4 doses in that 12 weeks, you are included in the data. And it's really hard with a therapy that you need to use for a longer period of time to hit the intent to treat analysis, and I think this really speaks very, very well. So concluding, looking at healing, twice as many people with topical oxygen experience complete healing, about 44% versus 28%, as statistically significant in both the per protocol and again, intent to treat. And obviously, I'm proud of that because we don't hit intent to treat very often in diabetic foot ulcer trials. So looking at this again, in the per protocol, we had a 52% healed completely, and we had much greater healing rate in the Natrox group, and a greater average reduction in wound size. Because we were doing this digitally with the camera system, including the artificial intelligence, we were able to look at the wounds and their percent area reduction of the surface area every week. And so we could draw lines to look at how they were healing. And when you look at the Natrox group, not only do they heal better, obviously we have a 52% complete healing. We've got a greater healing rate when compared to the standard of care, but also they healed faster. And from my perspective, this is also really important because the faster they heal, the faster they reduce in size, the less likely are to get complications. All right, so this is again percent area reduction, and you can see in both the intent to treat and per protocol, you see that there's a marked advantage to being in the topical oxygen portion of the clinical trial. So this is just a case. This is from the trial. We can see a patient comes in with a plantar diabetic foot ulcer, Wagner 2, and then before 12 weeks, it was closed. Similarly on this other ulceration as well. I think one of the things we noticed almost immediately, and with advanced products that work well, you really do notice this, and that is that you have more early healers. So we had patients healing in 4 and 6 and 7 weeks in the topical oxygen arm, and that's typical of a product that works well. And we were really excited to see that when we started digging through the data, and that's really what we want. We want faster time to complete closure, and we were able to achieve that with topical oxygen therapy. All right, so this is Omar Al-Jaladi. He's our Natrox fellow. The folks at Initech sponsored his fellowship, and in return, he did our long-term durability study. And what we found was that 78% of the Natrox wounds remained healed at 1 year, and 60% of the standard of care. So there's a durability. Now, this is not statistically significant because we didn't have enough patients to adequately power it. But you can see there's a very strong trend towards getting a better closure with oxygen. And to me, that makes sense because you're going to get better healing, you have better angiogenesis, you have better collagen formation, as I said in the basic science portion of this lecture. So we'd expect those ulcers to heal. And I have to give kudos, and that's one of the reasons I put his picture up there, to Dr. Al-Jaladi, because now, as I said, we were completing enrollment, and just about before 2 months before the trial fully enrolled, it was April of 2020. And I turned to the fellow, like we always do, and say, hey, go find all the patients that healed. And by the way, none of them will come into the clinic because it's the middle of the pandemic. We couldn't get the patients with ulcers to come in the clinic. Can you imagine trying to get a patient who's healed to come to the hospital during the middle of during 2020? And so I think he spent most of 2020 on the phone and on FaceTime and trying to find these patients. And he did a fabulous job of tracking them all down and found them at 3, 6, 9, and 12 months. And we were able to gain this information. And I have to say that that's really due to the diligence of Dr. Al-Jaladi. All right, so I'm going to talk about a consensus document that we used the Delphi process for. It came out of the Leaders in Wound Healing Conference that we held last May, and we had all these doctors in the room. So I said, well, this is a good opportunity for us to find out what they think. So we were able to query them, and using a Delphi process, we did 2 rounds. We came up with several conclusions based on this group. Now, this is a group that all used topical oxygen. There were 8 vascular surgeons in this group as well, and there were a number of those like me who used hyperbaric oxygen therapy. What they said, concluded, number 1, was that you should assess limb perfusion prior to applying topical oxygen, strong consensus, assess bacterial load, nutritional assessment, debridement, edema management, and then good offloading. I don't think anybody in this room would disagree that this is a workup that should be done prior to using any advanced therapy, and I think topical oxygen goes along with that. The consensus of the group was that topical oxygen should be considered in the following circumstances: delayed wound healing, and everybody agreed on that. You don't get 100% consensus with key opinion leaders very often, so I was really happy about that. Failure of prior therapies, even if it's standard of care, and then ischemic ulcers. And we had a lot of discussion about ischemic ulcers, and several of our vascular surgeons made us put in that little caveat following all efforts to revascularize the affected area. What wound types would tend to benefit from topical oxygen? I think the greatest consensus was on diabetic foot ulcers. You know, we now have several clinical trials that show benefit and a meta-analysis coming out that also shows benefit. Venous leg ulcers and ischemic ulcers, and there was a lot of debate about ischemic ulcers. Personally, I think that's a very good choice, but we did not have complete consensus, but we were able to reach a consensus that satisfied the Delphi process. How often should you use it, and what's the frequency of duration? Well, patients receiving topical oxygen should be seen at least weekly, and that was the consensus. There was a lot of discussion about this. I mean, this was in 2021, coming out of still in the pandemic, and so a lot of the investigators thought, a lot of the key opinion leaders thought that perhaps that frequency should be less. But we did reach a 70% consensus, which satisfies the Delphi. And then how long should you receive topical oxygen therapy? The wound should be reassessed for continuing therapy every 4 weeks. And the consensus was continue topical oxygen therapy as long as the wound's healing. And based on the Natrox clinical trial, you can see that that's something that makes perfect sense. This is the diagram that goes over the consensus document. This is actually published now. If you go to the Journal of Wound Care stand, it's in the journal for the World Union. I suggest you pick up one, and you can have this for your use. So there's quite a bit of evidence for oxygen therapy, over 6,000 publications.